We're going to talk a little bit about QI, evidence-based practice and research. Um, all of which I know are not the most sexy of topics, but hey, they're all good. So, my name is Dana. I'm the nurse manager in Omaha, Nebraska at Nebraska Medicine. We are a 24/7 critical care facility. Um, we've been here for almost 40 years now, and I don't know what else. I wrote a couple of chapters, edited a couple chapters. I do surveys, the accreditation surveys. I actually am the nurse editor for the most recent version. I'm the past president for the BNA. I'm married. My kids are grown. Yeah, I'm like,
Jack of all trades.
yeah. I hope to God I pass my master's degree program on Tuesday. Yeah, been working on that for 3.5 years. So yeah. And Heather.
All right. And I'm going to let Dana control the slides. My name is Heather Wheaton. I'm the current president of the Baramedical Nurses Association. And one of the contributing authors, Dana and I did a chapter together. And Dana, you also assisted with the 22 guidelines of care, which we worked together on. So that is, and I am work with monoplace chambers. I've been hyperbaric since about 2012, and my experience before that was about 15 years of trauma, ICU, open heart. That's kind of my nursing background.
Well, I didn't know that, Heather. We
Yeah,
started in HBO at the same time.
yeah.
Yeah, because I
So,
was in 2012 when I started. So
and that's where I am. So we do not have any relevant. We're not getting paid for this
no.
time today, and we don't have any disclosures for that. Our objectives are to describe the differences between quality improvement, process improvement, evidence-based practice, and research. Recognize internal and external factors that may precipitate the need for process improvement activities. Describe when performance improvement activities transition into research opportunities.
Sorry. Oop, I don't want to do that. I'm having trouble because yeah, I had my slides up and now you guys are all in front of it. So in my view. So I'm trying to fix that so that I can see
That's
my
okay.
slides. All right, let me go back there. Swap them again. All right. All right.
All right. So just a brief overview. We're going to, on the next portion is we're going to review quality improvement, process improvement, and basically the difference between the two, how we can measure quality, some tools that are available for us to use, evidence-based practice, research, and some possible future opportunities.
Okay. There you go.
And I don't have as many pretty pictures as Anthony does, but so it is a little bit of a dry topic, but it is very important. Quality and improvement. Some people get QI and PI, and I still have to really think about it to differentiate between the two. So, quality improvement is a systematic, driven approach aimed at improving patient safety, clinical outcomes. So, a possible improvement that you're trying to do is you have increased rates of barotrauma in your hyperbaric patients. So that might be the triggering factor or the risk or the problem that you're trying to solve or decrease, reduce, um, improve the safe environment, make reputation of your facility as a reliable source. It helps you identify what needs to be improved. Some of the tracking that you could do is tracking your barotrauma rates, your hypoglycemia events, monitoring your amputation rates, evaluation of completion of non-medical aborted dives. Like, what kind of process are we doing? Like, I've unfortunately have a couple patients that, oh, I forgot to go to the bathroom. So 20 minutes into your treatment, you're aborting the dive to get them out. And in a monoplace environment, that's not good. In a multiplace, we can kind of accommodate that a little easier, but in a monoplace, And then you have all the risk of pressurizing, depressurizing more frequently by just letting them out because they forgot to go to the bathroom. So working through processes to improve quality. So process improvement is optimizing the actual workflows that you identified as an issue. You're going to determine how to make the improvement safely and consistently. And some ways that you could do that are standardizing pre-treatment screening, standardized workflows, your pre-checklists that I'm assuming most everybody has for your startup and shutdown of your chambers, safety stops, structured hyperbaric drills with debriefs. And I'm going to make mention of what Gus mentioned about Anthony's videotaping of the drills and kind of like doing that as like a sports analogy and all sitting around, what can we do better for our next gameplay to prevent it? So if an emergency happens, no one's going to be, it'll be like, oh, this is just normal activity. We've practiced this many times. We're here for game day. Let's go. This is what we're going to do. And practice your egress drills and work through different worst case scenarios. So quality improvement focuses on achieving safe and effective patient outcomes, while process improvement focus on designing reliable workflows that allow these outcomes to be achieved consistently in a high risk environment. And I would think hyperbaric medicine is definitely a high risk environment.
I would agree with that. So when you think of quality, here is just something I found. These are just definitions that I could find online of what is quality. And if I ask every one of you, you'd probably come up with something even different or more than this. The one thing I think that most people can recognize is that quality is subjective. What I think quality is may not be what Heather thinks is quality, may not be what Anthony or Gus thinks is quality. So figuring out how we are going to define it, and we have to remember that what I think is quality today may not be what I think is quality 2 years from now. What do I mean by that? Let's take this gentleman here. This gentleman here has his, 1980 brick cell phone, mobile phone, and he thinks he is all that because this was state of the art. It provided a service that was never available before. This was high quality. Now, if I handed the person who normally uses this phone, the phone the gentleman at the top has, he is not going to have the same impression of what is quality. As Albert always says, it's all relative. So how do we measure quality? Let's hope it's not by weight. Just saying. Nobody wants to measure weights. So we're going to say it's not measuring weight. But one of the best ways to do it is to look at what is the Donabedian model or the quality triad. And what it does is, so Dr. Avitas Donabedian, back in 1966, before I was born, wrote a paper on how to evaluate the quality of medical care. The premise of his model is that you can evaluate healthcare quality by looking at the structure or the system and how it's designed, the clinical actions or the processes that ultimately shape the patient and program results. So when you think about structure, think about the foundational environment in which the care is delivered. It determines really what is possible for us as clinicians for us to do. So you think about your physical environment. What's your layout? Do you have monoplace or multiplace? How many chambers do you have? How are your infection control processes and designs? You have technology and equipment. You look at your EMR functionality, monitoring systems. I know some EMRs where the chamber actually charts the times and the information and the depths it goes to. That is a huge piece of measuring quality because that information is going to be accurate. It doesn't rely on me to make sure that I am charting on the right patient, that I didn't inadvertently put in the wrong ATA, so it's important. Your maintenance systems, and then your oxygen delivery systems and those. Your human resources, staffing, credentialing, competency testing, and that. And then just your organizational policies, your protocols, your guidelines, your emergency procedures, and what quality oversight do you have? Next, you have the process, and this is what we do, what the clinicians actually do when we're delivering the care. And it reflects the reliability, communication, and adherence to standards. The clinical execution, our assessments, are they accurate? How are we delivering our treatments? And how is our quality? It's our documentation of quality. Does it have the information that we need in it? The reliability of our workflows. Think about your handoffs, communication, scheduling, wait times for your patients. And then you have, do you follow guidelines? Are you adherent to your protocols? And are you doing your safety checks? Are you incident reporting and that even for near misses to help you to identify something and potentially fix it before it becomes a problem? And then your patient engagement. How are you doing with counseling and education and involving your patient in their care? Outcomes are how we measure the impact of the care that we provide. Not only it's the impact of the care on our patients, but also how it impacts our staff and our organization. So clinical outcomes. I'm sure most of you are looking at healing rates, complication rates, morbidity and mortality. I know that's a big thing in hospitals. I'm hoping we aren't having a whole heck of a lot of that in HBO. The operational outcomes. How often are patients, how long are their lengths of stay? Are they being readmitted? From our standpoint, throughput. Are our chamber uptimes? Are we, having problems and downtimes from our chambers or not? Our patient reported outcomes. This is their patient satisfaction, but it's also their functional status. They're able to do things that they couldn't do before. Their symptoms are improving, those types of things. Because sometimes we don't always have objective data, but having those reports from the patient helps us to be able to measure our outcomes. And then our safety outcomes, our adverse events, our near misses, and our incident trends. Any way you look at it, the goal is to do no harm. And To Err is Human, written back in 89, I believe, 99. The Institute of Medicine's IOM report, it really shed some light on those preventable errors that were really just kind of overlooked in healthcare. We sort of said, yeah, sometimes it happens. Since then, we're more than 25 years later. And yes, Maribel, did you have a question? Okay. So 25 years later, we're more aware in healthcare about trying to prevent harm, and we're striving to prevent harm, but we're still harming 4 in 10 patients, which is still a lot when you think about it. And so why? How can it be this high 25 years later? Well, the James Reason Swiss cheese model of accident causation kind of helps to explain this. It is a metaphor for how harm reaches our patients. And I'm sure everyone has seen the Swiss cheeses with the little arrows going all the way through. So it's based on a systems approach that recognizes that in order to prevent harm, you need to have a series of defenses, barriers, and safeguards, which are represented by your slices of cheese. Each of these layers have holes, inconsistencies. Sometimes they're opening, sometimes they're closing, sometimes they're moving. And if a mistake gets through one of those, you're probably okay. You're probably not going to have a major negative outcome. It's when all of the holes line up and that it gets through all of your defenses that something really catastrophic happens. And we all know really catastrophic things can happen in HBO. So we have to think about our active failures and our latent conditions. Now, active failures are unsafe actions that can harm if they get through our defenses. They're actually those things that are committed by us, by the people who are taking care of the patients. There's slips, which is where we have the correct plan, but we incorrectly execute it. Lapses, when we omit a step of the plan. mistakes, which is usually based on a misinterpretation of a rule, and even violations, which are when we know the rules and we make a choice not to follow them. It's usually not with a malicious intent. It's usually because of another factor that is affecting their ability to do it the way it's supposed to be done. And then you have your latent conditions, and those are actually hidden in the design and operations of your program. It's in the system, it's in the environment and the equipment. It can be ineffective training, communication problems, ineffective equipment, not having adequate supervision or staffing, or just unworkable procedures or poor design. So now, having multiple layers help to prevent the error from getting through all of our defenses. And our goal here, I don't know why I thought he looked like a Steve. I apologize. If anybody out there's named Steve, I'm sorry. He just made me think of a Steve. Our goal is to have a whole bunch of Steves, because doesn't he look like he is ready? He is going to stop every bad thing that could happen and harm our patients. Unfortunately, our reality is our defenses may look a little more like these guys. We come to work sometimes when we don't feel well, when we are extremely tired, when we're getting ready to go on vacation and we are rather distracted. Or, as Heather and I know, because we've been talking about it all week, how multitasking we at many things we've had to get done, or we're running late. So things like this affect how the active failures happen, those mistakes and lapses. It's the human factors. So what we really need to do, and when you consider what the Don Obedience model said, the active fails are a part of the process. It's the actual provision of how we're doing care. The role of QI is really to mitigate the risks of these active failures through strengthening our defenses and protecting against the latent failures. Now, I'm going to tell you, this is an AI generated, rather frightening image of latent failures and what it could do in an HBO setting. Not really quite sure why he looks like he's coming out of the, a pod that just came from, outer space that, fell back to the earth. But that's kind of what it reminded me of. But we, as a well-structured facility, we have tried to address the physical environment, and sure, we have proper technology and equipment, but we have to make sure that we have enough layers between a mistake, a lapse, a slip, any of those before it gets to our patients. So I know this is not the most enlightening topics in the world, so I like to give you real life scenarios, and I usually throw my team under the bus a little bit. So I'm going to tell you about a real-time latent failure that just recently happened. This is how I learn best. I learn by relating topics to how it works, how it affects what I do. So it doesn't matter whether you're working a multi-place or a monoplace. We all know we have checklists. We have our pre-treatment checklists. We have our startup checklists. We have all of these things. And we think by having all of these and doing these things that we're protecting the safety of our patients, right? Well, let me tell you something. I call this a failure, put a pin in it. For those of you who are multi-place, don't work in the monoplace environment, what you're looking at here is the handle of the door that has the safety pin that engages the safety pin, so it locks or unlocks the door. It's either engaged or disengaged. And we check this twice a day, or twice each day. So here's our checklist. It says, verify that the safety pin is engaged and the chamber indicator turns from black to red. Verify that the safety lock pin retracts when the chamber pressure is less than 1 and chamber pressure indicator is red to black. Great. We do that. You see, it's documented every day. Well, a couple weeks ago, chamber was actually on its way to surface, I believe, and one of the staff looked down and said, the pin's not engaged. Huh. The chamber was at 7 psi. And the pin was not engaged, which meant someone who didn't know what would happen could go up, open the door. that could have been catastrophic. We, of course, contacted Seacrest. They didn't know how this could possibly be happening. A technician came out and it was identified. I'm going to go back a slide. That these little, I don't know if you guys can see where the little tubes, the little hoses there, they are connected by onto a little nipple. And somewhere in the that line, one of the nipples got tweaked just a little bit. And I mean, it wasn't fully bent. It was just a little narrowing. But it was enough that it created enough resistance that it did not allow the airflow to go through that to let the chamber know at what point the pin was supposed to engage. This demonstrates a latent failure, how it can get through our defenses. Got through our first slice of cheese. Fortunately, our second layer of defense was our staff that was aware, had the training, and knew that this was a problem that we needed to address. Another failure that came along behind that was that we realized that so I happen to have three different models of chambers. I have a 3200 still, I have 3600Es still, and then I have regular 3600 chambers. And we realized as we started looking that the manuals from Seacrest don't all have the same information for your daily chamber inspection tests. We're working with Seacrest on that too. But so we thought we were doing everything right based on the information and knowledge that we had, but come to realize that I can't just wait to check to see if it's fully engaged when the light changes color, because that's not telling me what's happening as it's pressurizing and depressurizing. All right. We don't know, Gus. We don't know if this was a one-off or how long this had been happening. And that's the really frightening thing. We don't know. But I can tell you, we're keeping an eye on it now because we want to make sure.
Can I ask a question? I am very ignorant about monoplace operations.
Yes.
But so to check that box on the list, when they compress the chamber, do they have to look down at the pin and check and make sure it's in?
Yes.
Or each compression, or?
It's in the morning. We verify that it's working first thing in the morning.
But you don't know that it goes in every compression. I'm just.
I'll answer this. So we do, because we look to make sure the pin has moved to be able to open the door. The mistake happened because we would see that the pin was coming out and it was going in and coming out and going in with the checks, but we weren't looking at the pin and what the gauge was saying as far as at what pressure the pin engaged and disengaged.
Because I know Heather has Pahi chambers. My brief experience with a Pahi chamber is if you didn't go to the second step of closing the handle, the chamber would stop at 10 feet and you couldn't compress or decompress. You had to manually vent the chamber otherwise. And Pahi was notified and they said they fixed the issue. But I don't remember a visible locking pin for the door on the Pahi.
Well, and actually, that is new for Seacrest from a couple years ago.
We do not have a locking pin for our Pahi chambers. I did have a similar event with our Pahi, and I don't think it would have been preventable. One of our daily checks is there's an O-ring in the door, and you're physically supposed to feel around to make sure there's no cracks or anything like that, or any visible damage, and lubricate if as needed. I was probably about after my second air break, like 5 minutes into the second O2 period, and all of a sudden the chamber started to rapidly decompress. The gasket blew, and I could forcibly hear the air coming out of the side of the chamber, and I had to manually compress to slow the ascent to surface. But that was checked before that, and it was just it reached its limit and said, I think the O-ring was probably like 8 or 9 years old. So I just went ahead and replaced all the O-rings on all the chambers so they'll be the same age length. But yeah, we checked it just like the Swiss cheese model. Um, and we also had a pin engagement issue too, and I had a rapid increase one other time. And we have this metal pin that goes into the door, and if you try to engage it too soon, it chips and chips and chips. And so ours are almost 20 years old. I had to have the hinge replaced. It just got hit too many times early, and then it wasn't able to maintain the door seal, and it came up. So just practicing what you were saying, the closing properly will prevent any long-term damage and a possible rapid increase. And just
Yeah, I think it illustrates that skipping a step is one thing, but even if you do everything right, you can still have the risk. It's not risk-free.
no, by any
You have
means.
to be ready for that. Like you responded, you have to be ready for a bad event to happen.
Exactly. Exactly.
Sorry for interrupting.
That's
No.
okay. You probably weren't the only one that had questions, Des. So, how do you measure your quality and how do you identify it? There's a wide variety of quality tools that can help you work through identifying root causes, measuring your outcomes, or templates on just how to approach a problem. Now, purpose of this is not to go into all of these. I just like to provide you some real life scenarios and kind of talk to you a little bit about what I do. It is not a statement of any of the superiority of any one of these over another. It's just my preference. Okay. So if you really like using a fishbone diagram, use that fishbone diagram. Yeah, not my favorite. That's okay. But just so long as you know that you're looking at it and that you're using a systematic process. So first thing we did at a departmental level, I like the PDCA or PDSA, Plan, Do, Check Act, Plan, Do, Study Act, basically means the same thing. I like it because it's simple. It's easy to understand. It's easy to follow. And I'm going to tell you a little bit about a problem that we recently had and go through the steps that we did. So as I mentioned, we're a 24/7 facility. We have 4 monoplace chambers, and our volumes over the last 2 years have increased by like 40%. Yay, that's good, right? It is. But we realized that in the first 6 months of fiscal year 25, I had canceled or rescheduled almost 40 outpatient treatments to accommodate inpatients. Not terribly ideal for outpatients for us to do that. So we decided we needed to fix this problem. So the first step is to plan. This requires identifying your objectives, developing strategies, and creating an action plan. So our objective is to identify how can we treat both inpatients and outpatients with less rescheduling or cancellations. The strategies we came up with is we could get another chamber. Doesn't really solve the problem immediately because I only have 4 hookups and 4 chambers. So this would require construction and that costs a lot of money. And there's like a 6 to 8 week lag time just to get a chamber. No, that wasn't going to solve my problem. We could extend our hours. We could, and I could probably accommodate it with my nursing staff, but my providers cover for a 24-hour period. They work the shift and they're on call until the next morning. They were already here running 11, 12 hours. If we did another set of treatments, we're looking at 13, 14, 15 hours by the time we were done. And then in the event we got called in, it was just going to be too much. So we thought, all right, we need to adjust our outpatient schedules to leave openings for inpatient needs, which is what we decided we'd do. We designated one of our chambers for inpatient use only, which did decrease the number of outpatient treatments that we could perform in a day, which I know sounds a little counterproductive, but that was our plan. That's what we decided. So we moved on to the do phase and we implemented the plan, which is where you're taking action, testing the plan, testing the changes. This is usually kind of like where you see a trial or a pilot in a unit or something being done. That wasn't really something we could do. We're pretty, we're small. There's 4 chambers. Yeah. It's not like I could trial it on one chamber and see what happened. I needed to do it for all of them. So we jumped in and tried it. And like I said, assigned one chamber to be inpatient only. And then we made sure that staff were assigned to specific chambers. Because generally speaking, whoever was available, we usually have 2 or 3 nurses working. Okay, this one's over here taking care of this patient. Well, this one's going to go get the inpatient. There wasn't a set, I'm responsible for these chambers, you're responsible for those chambers. So we tried to do that because we knew we were going to need that to streamline the process for when we had more than one inpatient coming. I'm not going to lie, this was not a smooth phase. We made sure all of our staff were trained and we set the start date, and we looked at our outcomes. And we realized the staff and our providers were really struggling following the expectations of keeping one chamber only for inpatients. And they were constantly trying to accommodate patients who either came early or late. So we went to the check phase. At 3 months, we checked the where we were at, and we realized we'd only had to reschedule 13 patients. Well, that's progress. Not great, but it's progress. But staff weren't abiding by or staying by their specific chambers. They were still all over the place. And interestingly, our patients were waiting longer in the waiting room. And we, like I said, we were really struggling. Our staff kept, my provider kept going, but the chamber's open. They're here. That chamber isn't for that patient. And I tried, we had one in particular who I looked at her on a Friday afternoon where we had gotten 3 inpatient consults in an hour. And I said, this is why we don't put an outpatient in this chamber. It's because I couldn't have even started the first one until the outpatient was done if we had. So explaining that I need to keep one open because these patients will come, and sometimes they come in 3s. Interestingly, I realized that less than 10% of our treatments were starting on time since we changed our processes. And we had patients, our outpatients were going in all 3 of our chambers, but this one this day, that one the other day. And I was like, what is going on? So the ACT phase is the last part of this. It's the, where you're supposed to apply your improvements. Had this been successful, we would have standardized what successful changes were and ensured that all the staff were adequately trained and focused on embedding this into the culture of what we were doing. That isn't really what happened from our end. We needed to adjust and we had to return to plan. We had some improvements, but more opportunities were identified. So back to this. Our objectives. We added another one. How do we streamline patient scheduling and throughput? Because that was obviously a problem. So we streamlined our schedule of patients. Patient is scheduled to one chamber and one set time. We staggered our start times for each chamber a little more because we had always had a staggered time, but if we had a chamber open, somebody got put in it. It didn't really matter. This way, the person who got the first patient in was not the person who needed to get the second patient in, so that the 2 chambers could be managed by the same person without having to, I'm trying to get this one in, I need help with that. So trying to really streamline that process. And then we really had to set expectations for our patients. And we had to hold each other accountable because it fell back on we weren't always doing what we needed to. So we set expectations. We made sure our appointment times and chambers were correct in the EMR because that had been a problem. Our AVS was still printing off the old information. We made a super cool color-coded visual schedule board with magnets so that we can move patients, like, oh, we've got this, oh, they're not coming this day, so that we could make sure everybody knew what was going on. And we tested what was going on. We monitored it. And okay, we had some improvements on our patients getting into the chambers, like they were, which chambers and the staff that was assigned. Our wait times got better. And we had minimal disruptions for our outpatients. Yay, doing what we're supposed to. but our first treatment of the day was always late, which meant every treatment in that chamber was late. So we needed to figure out why. So we used the 5 why root cause model, which is exactly what it sounds like. You have to identify the problem and start asking why. It needs to be a clear problem. You need to know, like, what am I trying to find the why for? Sometimes you'll need more than 5. You not have to ask why 6, 7, or 8 times to get to the root cause, but other times you don't need to. You just keep asking until you figure out this is the root cause. So we had our problem. The first scheduled treatment of the day is consistently late. Why? First patient scheduled to arrive at 7 for a 7:15 treatment, and staff are not getting treatment started on time. Why? The staff can't get the chamber checks and prep the patient for the treatment by the start time of 7:15. Why? Staff come in at 7. The chamber checks take 17 minutes to complete. Oh, okay, well, I just identified our root cause. My patients are coming to be scheduled before I can even make sure my chambers are checked. So we had to go back to plan, and we had to identify our objectives. Added that next one. We need to identify our practices and changes to ensure that we can start our first treatments on time. We changed our treatment times to allow for completion of chamber checks before our patients arrive. And we also then have one staff member who comes in early to make sure all of the chambers are checked so that we can start on time. While we implemented the do for this, we realized where we had one nurse coming in at 6:45, we hadn't really identified our SMART goals, which should be the first part of this. We didn't do that. And as our objectives kept growing, we needed to make sure our goals were clear, because if we didn't, we will drift. If you don't have clear goals and know exactly what you're trying to achieve, eventually what you're working towards is not going to be the same thing. It will drift, it will shift. So, SMART goals. SMART goals are specific. This is what I'm trying to accomplish. It needs to be very specific to what it is. It's measurable. I can't just say it's going to get better. You got to be able to say how you're going to measure that it got better. You're going to say it's attainable. It would be unattainable for me to say that 100% of our patients are going to start on time and be in their appropriate chamber 100% of the time starting tomorrow. Yeah, it's not going to happen. It has to be attainable. It has to be relevant. How does it actually solve our problem or work towards what it is that we're trying to achieve? And then it has to be timely. We have to be able to measure what time you're going to try to say it's achieved by. Oh, clicked twice. So I came up with our SMART goals. Patient's going to receive their treatment in their assigned chamber at least 85% of the time within the next 3 months, which just meant has given us some time to get the majority of our patients to fix our process. Treatments will start within 15 minutes of our scheduled treatment time, again, 85%, and our inpatients will be treated in the inpatient chamber 90% of the time. Yay! So we went back and we checked, and we'd achieved all of our SMART goals. That isn't where it ends. Just because I achieved it doesn't mean that we stop looking at it. So we apply our improvements. We educated all of the casual staff so that they knew exactly what was going on. We formalized the message for patients about scheduling, making sure that they understood that if they asked us for an accommodation, if we could do it, it was only if we knew it would not impede something further down the line, another patient, and we let them know it's an exception. We won't do this all the time. We always now look at, because it used to be if somebody said, oh, hey, I have a such and such meeting, I'm going to be 30 minutes late, we'd just accommodate it. We'd figure it out. In order for us to stay on top of this and to get our patients in and through like we need to, we can't be that accommodating. Now, we review this at our staff meeting to see where we're at and to make sure that we're continuing to function as planned. Of note, we've only had to reschedule 6 patients so far during fiscal year 26. Yay. So it has worked. Now, one of the big things is documenting your QI. There isn't a standard format. for documenting QI activities. Now, I know that if you like went on the AHRQ site, there's something or other. That's a pretty in-depth type thing. I'm talking about like, okay, what are the little things you did? Figuring out that, okay, the pin didn't work, so we didn't engage, so we contacted Seacrest, we got it fixed. Oh, wait, we realized writing it down, that's the most important thing. So you looked at your project aim and your problem. Oh, that was supposed to say SMART. You can use a SMART aim or goal and then document the who, what, when, and why. Really, you're just writing what you're doing. Come on. You're measuring it. You're utilizing charts to track progress over time. Because just saying, yep, today it's done. We fixed it. And do you know that next month it's still fixed? You want to see and make sure that you're making improvement and changes over time and that you're ensuring that the practices are cemented into the structure of what your normal processes are. You can use like what's called a PDCA worksheet. I literally just have boxes P, D, C, A, but document the cycle in detail. Include what you planned, what you did, what it showed, what your next steps are. And then really keeping track of your team knowledge, maintaining a log of changes and reflections about how it's going, because your teams really are, they're who have to implement it. So if they're struggling with understanding the why behind that, it's important that you can speak to that and really get the buy-in you need. And then do process mappings if you need to, include charts or maps to visually demonstrate the sequence of steps. Honestly, okay, the most important thing is just document it. Just do it. I know you guys are doing QI and PI. Just make sure you're writing it down. It doesn't have to be in a special format, doesn't have to be all pretty. Make sure you're writing down what you're doing to take credit for it. Back to Heather.
Okay, so just to tag on back to the QI real quick, at our facility, we do huddle metrics. And so we actually tracked, that was one of our problems, was the first dive of the day was always late. And we made almost like a fishbone metric, but when we tracked every patient that was late, unfortunately, we found out what the why was. Our providers were not arriving on time for the treatment to be started. We thought that's what the problem was, but once we had the data collected to show our providers that that was the big issue, it actually made an impact. So now we have the data. It's just not us saying that's what we think it is. So once you have the data to support, if it's a big change that needs to be done in your system, having the data to prove your point will make a big impact. Evidence-based practice. Evidence-based practice is the process of shared decision-making between clinician and patients based on research, evidence, the patient's experiences and preferences, and the clinician's experience. The need for evidence-based practice is more crucial than ever. In this age of trying to be considerate of everybody's diverse backgrounds, their patient preferences, equity, inclusion, and trying to do all that is difficult. So you have to take a wide brush in viewing this, and also maintaining regulatory standards, striving and maintaining UHMS accreditation standards as well, cost, implementation, and just trying to figure out the why, the science behind it. So this is part of this presentation is in our chapter as well. I have copyright permission for the Iowa model for our book, but I don't have it for this live presentation. So Dana helped hook me up and have this cute little state of Iowa. So shout out to everybody who's from Iowa. The Iowa model is one of the most popular models to support evidence-based practice. It's proven to give guidance for nurses and other clinicians to make decisions about day-to-day practices, or like what's the why behind what's going on and how can we make it better, that affect healthcare and outcomes of our patients. It's most frequently used with the evidence-based model, and this may trigger like anger results, but magnet facilities, because that they highly recommend the Iowa model as well, and it's used by implementation experts and researchers. A quick Iowa model overview with some examples. So basically, it's incorporating QI and PI together. What is the trigger issue? And I'm going to go back to barotrauma for otic barotrauma for our ears. All of a sudden, your facility is starting to have an increase in otic barotrauma. What's the reason for that? So that's our investigation, which we're trying to figure out the why behind. And then you have to take into consideration your organization or your facilities goals and patient safety. One of them could be patient safety, risk mitigation, survey readiness. What are they striving for that will help support you to resolve your issue? Forming a team. It can't be a one-man team to solve a problem. So, speaking specifically just in the hyperbaric environment, it's going to be your CHRNs, your CHTs, your hyperbaric physicians, your safety coordinators, your quality team, your hospitals, safety officer. Those are just some of the few possible team members to help support a resolution of your issue, your trigger issue that you're working for. So the next step is let's do a deep dive onto the evidence to support or mitigate your trigger issue that you're going in. Some of them might be peer-reviewed research articles, best practices that are already out there and published. How about our hyperbaric guidelines are out there? Let's look at the probes in the UHMS manual. Those might be some evidence and to critique your evidence on the why behind there. Is there evidence to support a change in practice to mitigate your issue? So to put a pause on that for a second, I went through evidence-based fellowship, and one of my colleagues is she just finished her research fellowship. Mine was 12 months and hers was 18 months. I went through mine first, and my original plan was to determine eye vision changes in our monoplace patients. However, my advisor declined my proposal for my project because guess what? There wasn't enough evidence to support any practice change. She said this would be a research project. So I had to re-scrap that and do another project for my fellowship. And then when my colleague came up about 6 months later and started her research project, she did a proposal for a research and hers got denied and was told that that was evidence-based practice and you can't do this in the research fellowship. So I said, hey, my little project over here got denied in the evidence-based fellowship. Why don't you try this one? And so that's how we got our research an IRB proposal on our current research project that we're working on now. But so that is a big caveat to determine if it's going to be evidence-based or research. Pilot practice changes, standards, what do you need to do? Some examples might be, is there already best practice out there that says that you should do ear exams to document, for example, your TEED scores or whichever score is appropriate for your facility? Do we need to do a modified safety stop, structured safety drills? What do we need to do to augment our trigger issue that is occurring? And this goes back to the PDCA outcome we're going to evaluate. Did we get a reduction in our barotraumas? How are we going to adopt it, modify, or that totally didn't work. Let's go back to the planning again and see what else needs to be done. So we're going to reinforce through audits. How are we going to maintain? Let's just say we did achieve a reduction on our barotrauma or whatever our goal was. It was supposed to be like, we'll just throw it out there, 95% of our patients will have no barotrauma post-treatment. So we maintained our goal, but we're not going to stop there. What do we need to do to maintain that goal? So we're going to reinforce through maybe some chart audits, annual competencies, education, in-service, and then you want to make sure that Maybe some other facility is having the same issue, and you can share your results locally or through publications, presentations, poster board, podium presentations, or conferences that will help reduce the trigger issue that you guys are having as well.
I
You
don't
go
know.
ahead.
I sense a theme, Heather.
Okay, so this is props to my nurse that works in our unit. She is not a hyperbaric nurse at all and has no desire to go anywhere near a hyperbaric chamber. But she needed a topic for her fellowship, so she decided she presented that to her advisor, and it was accepted. So, into her research fellowship, and our IRB got extended because we are a small facility. Our goal was to get 120 patients on board with our trial and for the pilot study, and we were not able to do that. Our facility is one of the largest systems in Texas, so we are getting a few other facilities on board for collecting data, and hopefully soon by the end of the year we'll get our N of 120, and then hopefully we will be able to share that information with everybody. So the prevalence of hyperbaric, could you go back just one? Prevalence of hyperbaric oxygen therapy related myopia. And so I wanted to give a shout out to Ann Davis. She is the principal investigator. Our co-investigator is Dr. Penny Huddleston, and our hyperbaric nurses all went through the city training. Um, so those are Desiree Clark, Elizabeth Antonio, Christina, and Jennifer. And I think most of them are on the call. So I just want to say thank you for hanging in there. It's been a little over 18, 20 months now, but they're still out there collecting data. We only have two monoplace chambers. If you notice directly to the left of the left chamber, we have another door over there, and we have our Snellen chart, and then it's out of frame, but we have a painted line on the wall where our 20 feet are, and we incorporated that into our safety stop. Is when is their Snellen test scheduled? And we have that. It took a bit. We had to do some plan and redo again because it was a new process. In the beginning, they were getting missed, but it's turning out to be a pretty smooth process now, but there was some hiccups in the beginning. So these are a few of Anne's slides from her graduation presentation. So she used, guess what, as one of her sources was the Barometrical Nurses Association guidelines to care. So maybe when we get our final answers, we might be able to update our guidelines to care. So the current guidelines say to wait 6 to 10 weeks before corrective lens exams or other optic care is done. So that was the problem. So therefore, visual changes will alter the efficiency of corrective lenses and add to unnecessary medical spending. At the very least, longer wait times for treatment. Okay, go ahead and go. And so this is the study population that we are doing. The treatments approved for, they're having at least scheduled, at least planned for greater than 20 treatments. And we're only treating approved indications for UHMS guidelines, and they're medically fit to undergo hyperbaric oxygen therapy. One of the other hiccups that I didn't think would be a big thing is some patients just flat out said, nope, I'm not reading that eye chart. Don't want to do it. So we just had to think of different ways to kind of approach the patients that, hey, this would really help us out. It will help promote care for other patients, but we're still working on that for some of our patients that have, because it only take less than 2 minutes to do the Snellen exam, and some of our patients did not want to cooperate at all. The, the exclusion criteria. If you're blind, we're not going to be testing your eye exam. If you currently have cataracts, that's going to affect your ability to do that. If you're receiving hyperbaric oxygen therapy due to central retinal artery occlusion, currently have drug or substance abuse issues, participating in another study, suspected of poor compliance, having a hyperbaric oxygen therapy in the last 12 months, or having any kind of eye surgical damage, or if you're currently a contact lens wearer, that could affect the impact of that. Our goal is to have 120 patients, and we have not met that goal yet. So we're expanding. I think Lake Point is going to come on with us. If anybody else is interested in collecting data for me, please reach out so we can get our 120. Unfortunately, I can only, it's only for monoplace chambers. Go ahead next, because there could be a difference with the hood and the pressures with the vision changes. Prospective, so the recruitment is the prospective patients were referred to the wound center and are scheduled for their consultation. So we review the possibility of them participating in a research study during their consultation phase if we think it's appropriate. And then that's where we go over the history and physical, and they do the consent for the treatment. If it's inappropriate or they're a little overwhelmed and they end up being a candidate, we'll rebroach that on maybe another visit. And so in preparation for that, all of the hyperbaric staff, and is an all RN focused study. So all of the RNs have completed this city training to be able to collect the data for this research. So it's a prospective descriptive pilot study using, it is a convenient sample because we're in a hyperbaric center and we are collecting data from our hyperbaric patients that walk through the door for us. And the Snellen test is actually not the most recommended Snellen test anymore. It's the second recommended one, and I cannot remember what the other name is, but we went with the Snellen because most everybody is familiar with that, and would be less a new training for the people collecting the data. So recruitment is informed consent. We take the first Snellen test prior to the first treatment, and then we do weekly vision assessments. So the guidelines of care is to check your Snellen or your vision once a week. So we're adhering to the guidelines that are currently there to collect the data. So hopefully it's not too much of added work for other facilities to help collect the data. Go. And so it's just, again, going into the statistical methods, the data analysis of the current project we're working on. You can go ahead and next. And so the risk, benefits, and implications, minimal risk to the patients. There's no change in their hyperbaric protocol. Even if they withdraw from their study, we are still going to treat them, potentially aware of vision changes when reading the Snellen chart. Side effects of hyperbarics in general, not related to collecting this data. The benefits, we're going to gain the knowledge of knowing what vision side effects there are, increase the knowledge base of hyperbaric oxygen therapy in the community, improved experience for future hyperbaric patients by informed decision making, prove need for continued study. And so some evidence-based projects, research projects prove that, hey, we need to collect more data. It gives an avenue to move forward. Encourage other clinics to test visual acuity, preferably on a weekly basis. The Snellen is an easy chart to get. I think it costs like $15 or $8.99 on Amazon, and we got a whole bunch of different eye things there, and we painted a line on the floor. So it wasn't a cost prohibitive for your facility to do this. So hopefully our goal is to have other people continue the research and have better exact timeline on vision impact with our hyperbaric oxygen therapy patients. So future research, QI, evidence-based pro, opportunities. One of the ones that I was just playing around with, Gus knows a little bit about that, is, and also this is in relation, it got me thinking after the horrible Troy incident, is how can I modify the humidity in my monoplace chamber to help mitigate additional risks for sparks and fire. We do have one of the few chambers that runs continuous humidity measurements, temperature measurements, and PSI reading, and we graph that for it goes into the progress note of our hyperbaric oxygen therapy treatment notes every day. So I already have the tools to collect this data. So I have the temperature inside. I have a wall clock that tells me the temperature and humidity in our room. So I have the humidity monitor inside my chamber and I have a continuous reading. I just need to save my chart and upload it into my electronic health record. I have the continuous reading of my PSI in the chamber during the treatment. And I have we are checking what other some other factors that may change my humidity. Is the patient large? What is their weight? What was their temperature going in? So we do with our normal vitals, it doesn't augment or add more work to the staff because we already do pre and post vitals, which include temperature for our patients. So I already have the data that we're collecting. Let's see what we can do with all that together to see if we can modify some risks. And then we get just some subjective data, is ask them how they felt during their treatment, pre, intra, and post, and then what kind of modifiable factors can be adjusted. So we have the plastic bath basin that we use for inpatients, and we figured out that it fits under the dish pan in our gurney. And we have an ice machine in our unit. We filled it up with ice. And one thing that I want to do moving forward is I want to weigh it to have the volume of ice. We have blowers that we hooked up on tubes, and they can move them around. And of course, the vent adjustments. So we would track to see if we had our blowers on and what the event was tracked. And it was kind of interesting to see some of the data. I don't have the information with me today, but I want to move forward with that just to see what I can do to decrease the risk of spark fire by playing with how I can modify the humidity in the chamber.
Yeah, Heather, that's something we're looking at doing at our facility as well. I don't have the same type of chamber, so I'm going to have to put some type of a humidity and temperature tracker inside my chamber. And we're working on that and trying to figure out, because we all know that if you get to a certain percentage of humidity in your chamber, I mean, it's a high percentage. I don't remember exactly what Rob Sheffield told me it was. I don't know why 40 or 43%, which is a very high humidity. Nothing will burn.
Hey,
Yeah.
Dana.
Yes.
Dana. Steve Wood in the safety book on static electricity mentioned your goal should be 50%. In an area like Las Vegas, or even Texas, I can't imagine getting
No.
that level
No.
of humidity in the chamber.
I'm just
And
trying
I
to get
can't
near
imagine
40.
how uncomfortable a patient would be in that chamber at 50% humidity.
Yeah.
But I do know that when our patients complain of being hot, we turn up the airflow, which means I'm decreasing the humidity even more. So we're trying to figure out, all right, well, what can I do? What happens at what rate of my airflow does it change it? So yeah, this is something that we're looking at doing as well. Simply, and again, it was in response to the Troy, Michigan event. So
In the multi-place environment, we not only could do like a mister in the chamber, but we also had little spray guns that we could raise the humidity, because the humidity in Las Vegas is high when it's above
Yeah.
10%. So
yeah. Another thing that we're looking at for future research and evidence-based practice, QI stuff is, so we talked about TCOMs earlier, sort of. Anthony kind of missed that a little bit, but okay. We all know what they are. So I have a TCOM. My machine technically is at end of life, but I work in a large organization. It's still working. So they're not going to replace it
Good
because
old
it's still
Tina.
working. Even though technically, based on the years that I've had it, it's due to be replaced. Now, it measures the pressures of oxygen through your capillaries. This is the standards that are established. We know if when I do a TCOM and I do an oxygen challenge, if it goes up this much, they probably would benefit from HBO. We have those guidelines, we have those standards already established. But what I want to know is what if we use the Kent imaging NIR, which is the near infrared spectrography. So back to the TCOM. Yes, this is what we were all trained on. It was told us, we were told it was the gold standard. But those of you who have them, the machine's expensive. The disposables are expensive. That the manufacturer are recommending that the cables that are $6,000 a piece be replaced every 18 months is expensive. You also know it takes 45 minutes to an hour to do this. So, and if anybody else is like me, and again, my machine's old, you just heard me say that, sometimes I get results that don't make any sense. They make no sense whatsoever for what's going on clinically with that patient. So I don't even know that I can trust the results I'm getting. So I was looking to see what are my other options? What else could we possibly do? And we started this as a QI project just to determine and gather the data on what results do I get from a TCOM and what results do I get from the NIR, so that we will be able to see if we can find a correlation. There is not enough research that puts this side by side for us to even say there's enough evidence that, yep, this should be. Research is going to probably have to come beyond this, but I want to know, okay, because first of all, I can't even tell you the number of pictures I could take with the NIR in the 45 minutes it takes me to do a TCOM. I could take pictures of their entire body in that time period. Not that I would, but I could. So we're just simply recording, and we partnered with, because we don't have enough volume of TCOMs, because we only got to borrow the machine for a few months. We're in our 3rd month, and it has to go back next week. So we partnered with our vascular lab. So when the patient comes in for a TCOM in our vascular lab, we go over and we do this as well, just to get the data, just to begin to start to see how does it compare. Because what my goal would be then is the next phase is let's do some actual research to see, okay, if this is what TCOM says is when it's, yep, they're appropriate, or no, they're not appropriate for HBO, what would that mean on this? So again, it's based off of something that is, I don't really want to spend $60,000 on another TCOM. I certainly don't want to spend $30,000 every 18 months on new cables. So hopefully I can talk my organization into purchasing this, and we'll be able to get more data in that. I don't have any results of this, but hopefully next year we'll be able to present this. But again, the main point in why we wanted to tell you about these things is these are things that are probably going through your head too, is my TCOM machine's breaking down, or I need to get this. What else can I get? That's looking at QI. That is QI. That is what else? How do I improve my quality? So you are muted.
I just want to say thank you all for hanging in. I know we're a little over, but it just in conclusion, the Iowa model is the bridge between evidence, quality improvement, and process improvement. Research determines what evidence exists, while the Iowa model guides how existing evidence is implemented to improve nursing clinical practice. You're doing QI and PI, take credit for it, what you're doing, write it down, write it down. If it's not written, it didn't happen. So don't overthink it. QI, PI, evidence-based practice, and research. You have the tools, you can do it. It's not as overwhelming as it can see at a first glance.
All right.
If somebody wants to do anti-aging research, I'm available.
All right.
Oh.
At the end of our slide, we do have all of our references as well. They'll be on the presentation. So.
All right. And just again, we don't have all of our questions yet to obtain the continuing education yet. So you will be getting an email by the end of the week asking you to complete the questions related to the presentation and the evaluation. Once you've completed those 2 items, you will be getting your continuing education credits. Thank you all for coming today. And does anybody have any questions before we end?
Thank you, Tina.
Awesome. Thank you. All right. Everybody have a great day.
And happy
And
Hyperbaric Nurses Day.
Nurses Day. Yeah. All right. Thank you, everyone. All right,
You
Dana,
all
where's
did a
this?
great job.